evening and welcome. I'm Patty von Eiterstein. I want to welcome you to those of you that have called in today to a community conversation on behalf of the town of Belgrade with Dr. Stephen Sears. Tonight we're going to have a conversation led by Jay Bradshaw. He's a fellow Belgrade resident, a former paramedic and retired executive for the Director of Maine Emergency Medical Services, and serves as Executive Director of the Maine Ambulance Association. So, Jay, I want to thank you for being willing to lead this conversation tonight, and I'll hand it over to you to introduce our special guest.
Thanks very much, Patty. Before we get started, I would just a couple of quick technical things. I would ask those of you who are joining us on Zoom, if you would please make sure that your audio is muted and your video is off. That just helps us a great deal so we can focus on Dr. Sears and his presentation. We really want to hear your questions. The absolute intention of this forum is to have a dialogue. That Dr. Sears will be making some comments and getting this discussion started with some PowerPoint slides. But the real purpose is to hear your questions. We know that there are a lot of questions about the virus itself, about the vaccine, the rollout, just whatever's on your mind. This is your opportunity. We intentionally want this to be a casual conversation. For those of you who are joining us on Facebook, it's also being streamed on Facebook Live. You're welcome to put any questions that you have in the chat section. And Anthony Wilson, our town manager, and I will be watching that so that as we go through our time together, we can be sure to answer any questions that you have. So please mute yourself if you've got the ability to do so. Make sure your video is off. Think of some good questions. And let me introduce Dr. Sears. It's really my pleasure to introduce Dr. Sears. I've had the pleasure of working with him back when I was also working with the State of Maine Office of Emergency Medical Services. Dr. Sears joined the COVID-19 response team at Maine CDC in March of 2020. This was his retirement job, if you will. Prior to that, he was the chief of staff at the VA Medical Health Systems. He also worked as the state epidemiologist from 2009 to 2014. And he was the vice president for medical administration and the chief quality officer at Mercy Hospital from 2007 to 2010. Prior to that, he was the chief medical officer at Maine General Health Center. He has been the recipient of numerous awards that I just highlight some of them. He was recognized as one of the top 25 most influential people in the fight against tobacco in the previous 25 years by the American Cancer Society. He has been recognized for his expertise and contributions in reporting, monitoring, and prevention and control of tuberculosis in Maine. And he was just recently recognized by the Maine Medical Association and received the Distinguished President's Award for Distinguished Service. I think my favorite part of his bio is that he and his wife, Kathy, have 3 grown children, and they live in Belgrade with a canoe and 3 kayaks. So that tells us that his priorities are right in order. So Dr. Sears, thank you so much for taking time out of your very busy schedule. And I'll turn it over to you at this point.
Great. Thank you very much, Jay. And you note that there's only 2 of us, my wife and me, and we have four watercraft. But anyway, thank you all. Thank you for inviting me. And I do, as I've sort of chatted before we went formally here, that I really would just like to make this as informal as possible. I'm going to give some opening remarks, talk a little bit about, the last year, and that's going to be done in a very short time course. Show a few slides, really mostly about the vaccination program, and then hopefully get to people's questions. And as I think anything's fair game, this is really about all things COVID. For me, I work all day on COVID, so it's top of mind, and I've been doing that, as Jay said, since March 12th. Which is pretty interesting because if you look at the historical context of this, the virus was first described in Wuhan, China in 2019 in December. First cases, we started hearing about it in January. February, things started really heating up and we heard about a nursing home outbreak out on the West Coast. Seemed to be spreading very rapidly. And then a pandemic was declared by the World Health Organization on the 11th of March of this past year. One day later, March 12th, Maine had its first case of COVID. And since then, it's unfortunately been a pretty much uphill climb, enough so that in the past day, we just about reached 32,000 cases of COVID over that course of not quite a year, more like 10 months. And we've had significant numbers of people who have been hospitalized or had serious issues, lots of people who have not. The first wave, as we all sort of recall, it was a time of really there was a lot of anxiety. There was a lot of not a lot of understanding. We knew that we needed to do something. There was a response to close things down because, from a public health standpoint, we know that will help interrupt the virus transmission. And that's what, that's what the spring was. And we rolled into the summer and we had sort of what I call the summer lull, and things seemed to have quieted down and cases were under control. They were much lower. Most places in the United States were experiencing that. Maine clearly was. And I think we all would have hoped that's the way it would have been, but the predictions were that in the fall and into the winter, due to the sort of nature of this virus, we were likely to see it increase. And we really have. We've seen a tremendous surge of the virus starting really October, but more November and December, and now into January. And when I say a surge, that's the number of cases we see per day, the number of people who might need hospital care, who are being treated for COVID, has gone up pretty dramatically overall. And I want to just talk a little bit about why that is, because it was predicted, but it's we were hoping it wouldn't be, but in fact, it's what we see with a lot of respiratory viruses. Because one of the things that happens, in the winter is we tend to be indoors a lot more. And it's not just about being indoors, it's also about the temperatures, the humidity, all of the characteristics of winter favor viruses, respiratory viruses, and they all do well. We know that influenza comes in the winter, and clearly COVID has done that too. And it finds a more fertile ground as the humidity goes down. The virus probably is a little more active in each, as somebody exhales and out comes viral particles. Those are usually in like little water droplets. Those little water droplets are a little drier in in a time of low humidity. That the virus is a little more active. So it's probably two things happen. It's more easily transmitted, but it also stays more in the air. And so you keep more virus in the air, you get more people together, and perhaps not everybody is using all of the distancing and masking that we think are probably important for decreasing this virus. And it's just a perfect recipe, unfortunately, for the spread of the virus. You add to that the holiday seasons. If we start from really Halloween and roll through Thanksgiving, go to Christmas and then New Year's, people get together. And, it's as much as we would like people to stay as distant as possible. We know that there have been social events and people have had more potential for exposure. And so that brings us to where we are right now. And where we are right now, as I said, is at a point where the virus has increased pretty dramatically throughout the country. Clearly, it's increased in Maine, and it's been everywhere. One of my parts of my job is working with other parts of the state on outbreaks and trying to figure out ways to diminish the number of cases. And there have been cases in Fort Kent. There have been cases down in Calais. They have been along the coast. They have been into the interior, and they've been to the western and the southern parts. There really is no place in Maine that has been spared. Originally, a couple of counties didn't really have that much. Now there have been high rates in every county. Is Kennebec County higher than other places? No, we're probably a little less than the Cumberlands, Androscoggins, and Yorks, but we've had our share of cases, and Belgrade's had its share of cases. So what can we do about that? The simple thing is, I will always want to emphasize, we know that what's called non-pharmaceutical interventions. We don't have a drug to treat this really. So what do? We need to try to do those things that diminish the likelihood of spread. And that's wearing a face covering, because what does that do? It basically stops the droplets from going forward, and it keeps the droplets from coming in if you're around somebody with it. Try to maintain social distance. I like to think of it more as physical distance. I think you still ought to be social. And so you want to try to be physically distant, because we know that the virus will tend to drop out and not be as, you won't have as much exposure if you're 6 feet or more away from individuals. Washing our hands, and knowing that getting together in groups is really associated with the increased potential. So, we do all that, but we haven't been as successful with that as a strategy. And we've all been, hearing about, listening to, and waiting for a vaccine. A vaccine is always a public health strategy to try to really make a big dent in a disease. And, we can, for those of us who've been around a long time, you can really think back actually even to the 50s, when polio was a great scourge in this country. And there was an incredible need, desire, and sort of positive energy when polio vaccines were developed. And if you look in the kind of the history books, you can see all the school kids lining up to get vaccinated against polio in this country. And so we have a long history of trying to develop vaccines to prevent diseases. Are they the perfect solution? No. Are they going to get rid of everything? No. Does it mean we can get rid of the masks and the distances? Not for quite some time. But on the other hand, there's a lot of promise. And I'm going to talk a little bit about that. And I'm going to ask Jay to put up a few PowerPoints. It's just a few, and I'll go through those quickly and then get to questions. I always like to emphasize this, vaccines don't save lives. They got to be put into people, and they got to be put into people's arms. So it's really vaccinations that we're looking for. And so we have the vaccine, we are distributing it. People are being vaccinated. Yes, as of yesterday, there have been about 70,000 people in Maine who have been vaccinated. Next slide. You there, Jay? Next slide. Or do I do that? Let's see. I think, well, I'll keep talking. Jay, are you working on trying to advance that? I would guess, because I don't need it if we don't. Okay, you're back. And what the slide that I want to show is kind of the development of a vaccine. I think a lot of people have heard that this vaccine, specifically COVID, was developed very rapidly. You've got the PowerPoint up, and there we go. If you can get that one enlarged a little bit, because I just wanted to go through vaccine development, because maybe you've heard some of these terms, maybe not. But this works for any vaccine, but this is clearly what happened with COVID. First of all, we go back to last year, December, January. We figured out that what's called SARS-CoV-2, that's the virus that causes COVID, and it was immediately broken down. We figured out its genetic code. The genetic code was taken out and it was put into a vaccine. And the vaccines that were the first that we've seen with success are what are called mRNA vaccines. And that's just taking a little bit of the genetic material of the virus and using it in a vaccine. But in any vaccine, you start by doing some animal studies, you do some laboratory studies. If that all shows that you've got something that looks promising, you put it into a small number of people. That's called a phase 1 part of a trial. And then if that's successful and it's safe and there aren't side effects and it seems to be effective, you go into phase 2 trials. That's a bigger bunch of people, and it's usually people with both a lot of different ages and different characteristics. And if that seems to still be effective and safe, it goes into phase 3 trials. Phase 3 trials are what you've heard about. That's the either the Pfizer or the Moderna, where it goes out into thousands and thousands of people. And when that has been completed and there is enough data to show that a vaccine is both safe and effective, it can be submitted to the FDA, Food and Drug Administration, who they have an independent advisory group of clinician, doctors, and public health people who look at the data. They are really not part of the government. They're an independent group. They will look at how things, whether the vaccine looks safe and effective. They will recommend to the FDA. The FDA then will have its own folks who will look at it and say, yes, we think this is worth giving. It's, in this case, it's not called approval, it's called an emergency use authorization, or an EUA. It is also then sent to the CDC, to one of their groups, which is called the Advisory Council on Immunization Practices. Again, a group of doctors and public health individuals who do not work for the federal government. They look at it and they recommend to the CDC that this there we go, that this should be approved or not approved. And so the reason people have said, well, this is really fast. Well, it is. And what I want to do is just say how some of that came to pass, because usually we do phase 1 studies, we wait a while, we do phase 2 studies, we wait a while, we do phase 3, and so on. And what was done with this is they were actually stacked on top of each other. So phase 1 was being done, and as soon as it looked promising, phase 2 was started, and as soon as phase 2 looked promising, phase 3. And so all of those continued at the same time, which shortened the period of time that it took to get this vaccine approved. The only things I would emphasize from this is it had a large number of independent clinicians, scientists, and public health folks who have looked at this and looked at the data to make those approvals. Let's go to the next slide, if you can. Well, I'll just keep talking because, you
don't see the.
I see the vaccine. I'm just not, I can't forward it.
No, the screen that I'm looking at says.
Got it. Changed. Thanks.
Sorry about that.
Perfect. Okay, so what we have are what are called the mRNA vaccines. It's Pfizer and Moderna. So as I said, the vaccines, they have been rigorously tested. They have been found to be safe. They have been found to be effective. mRNA technology, it's mRNA stands for messenger RNA. It is a piece of genetic material that goes into our ribosomes, which are part of our cells, and they produce a protein. And that protein is a protein on the outside of the COVID virus. And it's produced, and our body makes an immune response, which is the thing that fights off infections. And this turned out to look and be more effective than I think anybody really thought it was going to be. mRNA technology is not new, but this is the first vaccine of this type. And I think that's important for everybody to know. But mRNA technology has been around, and there have been other vaccines that have been developed, but they haven't gotten as far as COVID vaccines in the development phase. These vaccines, they don't contain a live virus. They don't go into our nucleus. They can't cause DNA problems because they don't go there. And it's really it's a very clever vaccine because it takes this little genetic code mRNA. It wraps it in a little bit of what's called a lipid, which is kind of like cholesterol, sort of, and you get a shot. It takes your cells produce these proteins, the spike proteins, our body makes an immune response. And so if you get exposed to COVID, you don't get it. So it's both very clever and very sophisticated overall. Next slide. What do these things contain? People are always concerned of what vaccines might have in them and what they don't. So if you look on the top part of this slide, this is all that's in this vaccine. It contains the mRNA. It contains a little bit of what's called polyethylene glycol that stabilizes the mRNA inside of this lipid coat. So it's got these little fats around it, and it's got some salts and sugars. It does not contain live virus. It doesn't contain fetal cells. It doesn't contain egg. It doesn't contain any preservatives, thimerosal, pork products, a lot of things that people have been concerned about with vaccines in the past. So this is really a little bit of, it's really just a little tiny bit of fat with this mRNA inside of it. One of the things you may have heard is it requires like really, really cold freezers. And the reason for that is this protein, this genetic material, mRNA, is it's very unstable at room temperature and will ultimately degrade. And in fact, after it's done after it's made helped make the immune response in our body, it degrades and just gets absorbed, and there's nothing left after that. Next slide. There we go. There are two vaccines, Pfizer, BioNTech, and Moderna. They're remarkably similar, and so that a lot of people are receiving one, and some people are receiving the other. They're being distributed. The Pfizer is the one that requires -70 degrees. If you look there, they contain the same stuff. They were found to be the same degree of effectiveness or efficacy. They have the same amount of reactions or side effects. Difference is that the Pfizer is usually given at 21 days after the first dose for a booster, 28 days for the Moderna. The trials with Pfizer were done in 16-year-olds and older, and for Moderna, 18 years and older. And I think it's important to point out that these have not been tested in children, and these are not yet authorized for children. And as I said, one of the major differences is the refrigeration requirements. Next slide. Safety. A lot of people are very concerned about what the side effects might be. What happens when most people get this vaccine? The first dose, they get a sore arm. Maybe they get a little bit of swelling at that site, but most people tolerate it very well. I've talked with a lot of people who've gotten this, and they said, boy, it's not like probably any other shot. The second shot, whether it's like 3 or 4 weeks later, can give a little bit of a little fever maybe, or a little myalgia, chills, headache, a little fatigue. That if you get it, it lasts for maybe 1 to 2 days. It usually occurs about the evening after you get the vaccine. But again, 50–60% of people don't have anything. They just sort of go out, what's the big deal? The way I look at that is when you get those sort of side effects, that's your immune system fighting what it sees as the COVID virus, and it's developing a healthy immune response. And that's what we want. We want your body to develop a good antibody response so that you can be protected against this. In the trials that were done, the side effects occurred more commonly in younger individuals. People over the age of 55, the rates were less common overall. It does not cause any of the signs or symptoms of COVID. It doesn't cause cough, shortness of breath, sore throat. It's loss of taste or smell, or any of those things. But it can cause people to feel a little punky for a day to at most maybe 2 days. Next slide. So we have this vaccine, we have this bad disease, we want to get people vaccinated. And so there are, what we call tiers or phases to try to vaccinate the people who are at the highest risk, then the people who are at the next highest risk. And as soon as we can, this will be distributed through past all of those high risk individuals to the entire population. What's called phase one, and then there's a subsection. The highest risk individuals are healthcare providers, people who are taking care of those who have COVID, those who are in emergency rooms, in the hospital, in the ICUs, and as well as individuals who live in long-term care facilities. We know that this has been a devastating disease in nursing homes, and that's where we have seen a significant amount of both disease and a lot of death. And so those are the very highest risk individuals. So those were selected as a place to provide vaccine as soon as we had it available. After that, it's going to be expanded to essential workers and then adults with high risk conditions. And just yesterday, Governor Mills moved up adults age 70 and older into the higher risk, higher tier group to try to get individuals over 70 in as soon as possible once we get through the phase 1A. I think the people always are asking me, well, when's my turn, or what's the lineup? It's hard to say exactly for any one person. There's a lot of different factors, but I emphasize to everybody that it's not a question of if. You will get the vaccine, will be available if you want it. It's when. And so people also want me to kind of predict, and I can't really do that, but I think that the phase one, the medical providers and the nursing home residents will be vaccinated by the end of January. That's sort of plus minus in the last week to the first week of February. Soon thereafter, there'll be an expansion into adults with high risk conditions and those over 70 years. Included in that grouping will be what are called critical infrastructure workers. That includes policemen, firemen. We've already begun to start vaccinating the EMTs, and most of them have been vaccinated, which is a strategy that's important because they will also help us vaccinate other individuals. And so the planning for both clinics as well as places and ways for everybody to have access to the vaccine is really underway at this point. And I'll take more questions if people want to try to ask some specifics. And so that's the last of the slides. We'll come back to, I think that's the last of the slides. And I want to just sort of finish up and say that it's actually remarkable. It's remarkable that this virus came, that it has created such disruption, such disease, such real challenges for people in their personal lives, their health, their social interactions, our society, the economics. There's never been quite anything like it in clearly the last 70 years or more. It's remarkable that we have the scientific technology to figure out how to make a vaccine and to then have that vaccine available and proven to be successful. I think people, I know I was pleasantly surprised on how effective this vaccine appears to be. It was unexpected in some ways, but it's very heartening. And it's now being rolled out throughout the country and throughout Maine. And within the next, several months, we're going to start seeing significant numbers of people vaccinated. And so I'm going to stop with that. And as I said, I'm really interested in your questions and what you might like to know either about the virus or, the vaccine or any of those issues that we might want to talk about.
That was excellent. Thank you, Dr. Sears. I just a couple of quick questions that came to my mind as folks are submitting their own. I read that there was some recent changes in the Operation Warp Speed distribution, where the plan, do I understand correctly, the plan now is to just, rather than withholding the second dose, to just ship everything out. Do you see that affecting the timeline, and how will Maine help assure that if people get the first dose, they get the second dose in the event that there's a supply side issue?
Yeah, I think that's a really very good question, because some of the very specific parts of this have not been totally worked out. The expectation is that the two companies will be able to produce enough to create second doses. On the other hand, a lot of if Maine gets all of their doses, and first of all, this has been talked about, this has actually not happened yet. We're kind of working through how we logistically keep track of vaccine and do exactly what you said, is work with organizations that are vaccinating folks. When I say that, there'll be vaccine clinics, hospitals that will be vaccinating, clinics are going to be vaccinating. There's going to be ideally lots of opportunities and geographic distribution. But those organizations will also, as vaccine begins to roll out, at least maintain some in reserve to make sure that we don't get caught without being able to provide the second dose. It's really a balancing act, because the goal is to try to get as much vaccine out as possible, because even after one dose, it appears to be about 50% effective. That's from both of the trials, and both Moderna and Pfizer appeared to be that way. So the logic is that if you're able to get it into a lot of people, you can decrease the pandemic more rapidly, but you do want to make sure you can have the second dose. I think it's also that there probably is more leeway on the back end. So even though we say it should be 21 days or 28, there's probably more what I call wiggle room that you could probably go. If you went 5 or 6 weeks, it's still going to be very effective. Ideally, we want to make sure people get their second doses in the time frame that the trials showed were most effective. But a little more to come.
When people get the first dose at that time, are they also scheduled for the subsequent dose?
Yes, they are. And in fact, the way things work right now, before we sort of have been hearing about changes, is that second dose was actually held back. And so we would, if you got your first dose in 3 weeks, we would put in and order your second dose at that point in time, and it would come in, and there'd be a second dose clinic set up, as opposed to just a first dose clinic.
So I'm thinking, we get a lot of summer people that will come in here. The potential for people getting their first dose in another state, then traveling up here and looking for the second dose.
Yeah, there's that, and there's actually a lot of those little nuances where things happen, where somebody, like, we've already had people who might have gone to a long-term care facility and they were going for a couple of weeks. They went there, they happened to be there when the vaccine was given. Now they're sent home. How are they going to get their second dose? It's the same concept. Ideally, what hopefully will be occurring is that the actual vaccine production is going to be so great that there will be more vaccine available and to be able to be distributed, and that there'll be, in a sense, surplus set aside for all of these perhaps not fully thought through situations, just exactly that, where somebody might have gotten their first dose in Florida. I do know, for instance, in Florida, because I looked on their website just to see what they were doing, because they're in the news a lot. They say that unless you are planning on being there for your second dose, they will not give you the first dose. Oh. So that's another, and that's on when you fill out a lot of places have online registration. And at least this was Sarasota County that I looked at.
One of the questions that came to us posted from a listener is, what happens if a pharmaceutical company doesn't get enough volunteers to trial the vaccine? They read that these companies are having a challenging time getting enough adolescent volunteers.
Yeah, and that's a really good point. I actually saw the data today that both Moderna and Pfizer are trying to um, get better data in adolescents and in children so that we can be comfortable in providing that vaccine. And Moderna's having a hard time recruiting um, the requisite number. And if they can't get enough, I mean, ideally, the first thing they do is they increase the incentives and they increase the populations. So a lot of these vaccines, a lot of these populations were not just United States, they were all over the world. And all of these vaccines have been tested all over the world. So um, whether it's Moderna or Pfizer or the newest one, which is probably AstraZeneca or maybe Johnson and Johnson, which are a couple of the new vaccines coming, they're field testing these all over the world. It's kind of one of the things that you want to be able to do when you are doing field trials of vaccines is have a high enough potential for people to be exposed to the disease that you can show that the vaccine is actually effective. And so this has been done. This vaccine has been in parts of the United States where the rates were really high. It's been in Mexico, Brazil, South Africa, and a lot of other populations where there are significant disease transmission still going on. If we could not get enough adolescents in the United States, they're going to expand those populations as broadly as they can, because we need to answer those questions. I mean, the first trials answered the most important question, which was for essentially, let's say 18 to 88-year-olds, this is an effective vaccine because they're able to recruit individuals in all of those age groups. They were also able to recruit people in different ethnic groups so that they can say that there's no does not appear to be any ethnic differences overall. It's incredibly important to be able to do that because you can't just extrapolate and say, okay, well, we did this in, if we just tested in people in Maine, we couldn't necessarily know that it was going to be effective in other individuals that might have a different ethnic background. And so we've gotten a little, I think the companies have gotten a lot smarter in they originally didn't have trials that had enough diversity in it to make good judgments on whether the vaccine and or new drug was going to be effective in different populations. But it's a good question because we do want to know what's going to happen in kids because that's going to be a really important group to vaccinate ultimately.
What about pregnant women? Same
thing. Pregnant. The groups that were not included were kids, pregnant women, people with severe immunocompromising diseases. But having said that, the groups that have looked at the issues with pregnant women, and when I say that, what's called ACOG, which is the Academy of Obstetricians Gynecologists, and as well as the CDC, have said that there's no what we call a contraindication. It means that if someone who is pregnant wants to get it, there's no reason that they can't. The future trials will probably be done, but we know that there are vaccines that we try to avoid giving to pregnant women. Those are what are usually called live virus vaccines. This is not that. This is very much like a flu shot in many ways, in that it contains a non viable particles this is a little different in that it has a different mechanism, but it's not live and it doesn't have any of the potential risks for pregnant women. Having said that, we don't have strong enough data for me to be able to say that it's absolutely safe, but by and large it looks that way. And there were a fair number of women who became pregnant inadvertently during the trial. I mean, if you think about, in those two trials, there were 75,000 individuals, and half of those getting the vaccine. Some of them became pregnant, and there's no problem with it. There's no problem with this in the laboratory testing when if you look at trying to do animal studies and whatever. But those, we don't have large populations of pregnant women. Likewise, people who have really significant immunocompromising disease, those are usually cancer on chemotherapy or certain types of lymphomas, things like that. But there's an important point, is that we know that both pregnant women and those individuals with immunocompromising disease when they get COVID, they get it worse. And so there's lots of reasons that why the vaccine is safe. And so it's now recommended for those immunocompromised individuals. The CDC has come out and put out some guidelines, but it's always still something to talk with your own doctor about.
Is there any early indication on how long the vaccine will be effective? And is this the type of thing for which we would expect to perhaps get a annual booster or something down the road?
Yeah, good question. And the answer is no, we don't know exactly. But for most of viral vaccines like this, I would think we're looking at a year to 2 years of immunity at best. And so, if I were guessing, and this is pure guess, this has nothing to do with scientific data. We're probably going to see a yearly booster. Might be there'll be some clever people who actually make a combined flu COVID vaccine in the future, so you should get one shot for both. And I actually know there's a lot of work being done on that. The Moderna folks think it's going to be good for 2 years. I think there's two things going on. One is, how long does our own immunity last? But also, does the virus do we get some mutant or variant strains, which we've been hearing a lot about? And will we need a new vaccine against those? So far, the variants seem to be, the vaccine still seems to be effective, but that's the nature of these types of viruses, is they just continue to change.
Question that was submitted is that we often hear that vaccine is 95% effective. Is that efficacy measured against mortality, severe symptoms, or some other measure?
The specific efficacy for these two vaccines was for clinical illness with COVID, with SARS-CoV-2. And in the subsets for severe clinical illness, it was highly effective. And so the efficacy for severe illness was also in the 90s or more. And so it's what we don't know, okay, is, does it totally prevent you from getting asymptomatically infected? Can you catch the virus and carry it around? Those are some questions. Those are some unknown questions at this point. But what was measured for was clinical illness.
Let's see. Another question was, there has been at least one large study out of China indicating effectively zero transmission from asymptomatic carriers. Is your position that a vaccinated person that becomes infected is unable to transmit, or unlikely to transmit, or less likely to transmit?
Yeah, I think, this is going to be, what do I think? And it's what I think, okay? It's not based on data. That was what we need to do is to see what happens after people are vaccinated, and to get and do sort of continuous viral cultures to see whether they actually become positive and whether they can be asymptomatic transmitters. I think it's going to be significantly less. Would be my guess. But that's a guess, and that's not based on data overall. The Chinese data is pretty hard to actually interpret, and some of it is there's been some places where the Chinese vaccines have not been seen to be as effective as they were in some of the earlier trials. So, and most of those are what are called adenovirus vaccines. But specifically to the question asked, We need to know that ultimately. We don't know it at the moment, but because we don't know it, it's still recommended that people who have been vaccinated continue to use distancing and masking for the time being until we get more data to say that that person cannot be, a transmitter, although not sick. Does that make sense?
It does. You mentioned a couple of other vaccines that are coming along, AstraZeneca and Johnson and Johnson being among them. I guess at some point, should people, I don't want to say wait, but should people, how do you sort of weigh which vaccine to get, or do you weigh,
Yeah.
get better? It's like, how do you?
I think at some point in the future, we'll probably have the luxury of making that decision. In the short term, it's probably going to be what vaccine's available, and does it appear to have good efficacy? Because the waiting for the perfect answer is going to be, you're going to I forget what that is, looking for the perfect but giving up the good. These two vaccines, as I said, I think nobody was really thinking they were going to be this effective. But if we think about, and I probably didn't explain it completely, but it really mimics the disease in many ways. And it doesn't cause the disease, but it's mimicking the spike protein, which is what we know is what binds onto our cells, and then the disease starts coming from there. And it does that with our own cells being very active in that process. So these are very effective. The next ones are really very different mechanisms. And so it's hard to compare them. What I think we need to do is compare the vaccine efficacy. They're not going to get, even at their best, we're not going to get much better than 95% efficacy, because even some of our best vaccines aren't all that much higher than that. And some of the ones that we take routinely are not there at all. And so the Johnson and Johnson and the AstraZeneca, they utilize taking a different virus, and which doesn't cause disease, and putting in these same proteins, these spike proteins. I mean, all of these vaccines are geared to trying to get us to make antibodies against this spike. If everybody's they've seen a picture of the COVID vaccine with the thing sticking out. Those are the spikes. And if you have antibodies against that, it blocks it from binding to our cells and starting the disease. And so those two, they're very different viral vectors, and the one, some people are saying, well, I want to wait for the Johnson & Johnson because it's theoretically going to be one shot. I don't know if it is or not. They're testing it to see whether two might be useful, but that's a different mechanism. I'm hoping they're as effective, because I'm hoping all of these are effective, because what I don't know is, will using more than one be more effective? And so lots of questions to be answered. My advice for people is, if you have the opportunity to get a vaccine and it's one being offered, get it, because you don't know when the next one's going to be available. It's really a daunting task to try to figure out how to vaccinate 330 million people in the United States. And if we just take it down to, our population, 1.3 million. And if you take out the kids at the moment and you sort of say, well, that's still 900,000 people. There's a lot of logistics of getting that done. So we'll be doing it with the vaccines we have. And if another one comes along, it'll just give us more opportunity to vaccinate more people. The final one to know about is there's a vaccine. It's a company called Novavax. That's probably coming along too. It's in phase 3 trials. Whoops. And that is that's the spike protein itself, creating that, created to be a vaccine. So lots of exciting stuff coming down the pike.
We have a question about frontline workers are being offered the vaccine, but family members are not yet. Is there any consideration for vaccinating family members of frontline workers?
Not at this point, because the frontline workers are the ones that are being exposed, and if they are protected, then they should be able to there should be protection against their family members from, at least from not their family not bringing it to them overall. There's lots of different strategies that can be looked at to try to say what's the best way to vaccinate folks, but it's the frontline workers and then it's what we're really going to be trying to get to also are those people who are at the highest risk for severe consequences, and that's as I said, that's the nursing home, those are the people over 70, those with significant underlying conditions, because we'd like to try to minimize mortality as quickly as we can.
Person observes that in at least one state, Virginia, it's been reported that there are too few people available to administer the vaccine. Will Maine be training additional staff, such as EMTs, to administer? And you touched upon that earlier, but certainly even when you look at the numbers of, you take 1.3 down to 900,000, that's a lot of arms.
It's still a lot of people. It's a lot of people, you know, because I can sort of go, wow, we've vaccinated 70,000 people. Then I go like, well, there's a few more. So the answer to that is yes and yes. There's actually part of the CDC is a group it's called Maine Responds. It has a listing of volunteers like Jay Bradshaw, who might want to sign up and become a vaccinator, who has had some medical skills. And it really seriously, we have a listing of volunteer doctors and nurses to add to our ranks of people vaccinating. We have also talked with the nursing schools, the medical schools, the pharmacy schools to get all of their students, all of whom can be trained to vaccinate, so that to start out with, no, we would not nearly have enough people to do this, but we have trained or are training all the EMTs as well, so that and a lot of the vaccination is occurring in healthcare settings or at your doctor's office or at a hospital. Where they'll be holding clinics, and there are trained people to do that. But nonetheless, it's a lot of people that you need, and a pretty big logistic challenge. But that's sort of what's going on behind the scenes.
There's a question about the level of EMT, and Dr. Sears, if it's okay with you, I'll be happy to take that one.
Yeah, why don't you take that, because I don't want to like step in the wrong place here.
I'm happy to do that, because the scope of practice for EMTs had been that they were only able to do injections with epinephrine, the auto injectors. That has been changed, and there's actually a training program so that EMS providers at EMT, advanced EMT, or paramedic are able, with the additional training module, to administer this vaccine. Now, EMS providers have been doing vaccines for years. I mean, when Dr. Sears and I worked together, you know, that we were doing, EMS providers were very instrumental in the H1N1 vaccine back in 2009 and 10, and now that's been expanded. So the short answer is yes, they are. There's also been ongoing discussion about how to use EMS for community vaccinations, and not resolved yet is, given that EMS is mobile, is there an opportunity to take advantage of that mobility to get to people who may have a difficult time getting to a clinic? A lot of these, as Dr. Sears mentioned, a lot of moving parts yet to be determined.
Yeah, and I think that's important, because we could have lots of fixed sites, but that may not, you know, some people, transportation might be an issue. There's a lot of different aspects. We also, and I can't remember if I mentioned it, but we also will be enlisting a lot of the pharmacies and the pharmacists who are licensed to be able to give vaccine. And there are pharmacies in most communities that are fairly located geographically throughout the state. So that's going to be another resource.
So a question about Maine Responds is where we should go to volunteer. The short answer is yes. How does one find that?
Maine Responds. Let me. I signed up myself, so I'm just trying to remember what it was. Maine Response .gov, I think, would be my. But I don't want to. I don't like to say things that I don't have the answer. I can certainly get that for you.
It's maineresponse.org.
.org. Okay. Yeah. And it's just, there's, there are forms you need to fill out, and then there is a vetting process. But if you are interested, and as I said, I don't know what all the opportunities are going to be, because we're working on a number of different directions at the same time.
So putting on your crystal ball, what do you think the summer of 21 and, a year from now look like? If we're successful in doing vaccines, wearing masks and things, when will I be able to hug my granddaughters again?
Yeah. My crystal ball continues to be really kind of cloudy. And people have been asking me this one since like last March. But let's just fast forward and say we are able to vaccinate 900,000 people in Maine, and 250 million people in the United States. Probably those are overestimates because some people will not be able to, will decide they don't want to, whatever. But still, if we get to the vast majority of individuals, and we are able to show that the vaccine has a longer term efficacy, it continues to be good for a while, then I don't think this summer is going to be quite the time exactly that we can throw away everything, because we're just, we won't get there until probably the end of the summer. But having said that, summertime's better. We're better when we're outside, the air, all those things I talked about with the humidity and being indoors, we have that to our advantage. And so I see some amount of normalcy coming in the end of the summer. I see clearly that the following fall and winter are not going to be as desperate as they are now. But I think we're still a year away from, seeing what I would like to say is control. I don't think we're going to see the end of COVID. I think that it's going to become one of the background viruses that will ebb and flow. And just like we see with influenza, we see outbreaks, even though we know that we can try to do something about it. But it's going to be so much more under control. And instead of being an almost ever expanding outbreak, it will be more of what we call endemic, which is localized response and control. I'm hoping that international travel will become easier and more possible in 22. And clearly by 23, because that requires the rest of the world to be vaccinated too. I mean, so when you put into the equation, our 330 million, and then you try to add all the numbers of Chinese, Indians, and Asians, and Africans, and all the people that we need to try to get this under control. It's going to be at least another year to two, I think.
Well, we're heading to the end of our hour together. Before I'll toss it back to Patty and Gina Coppins if they want to have any closing comments. But I just want to thank you, Dr. Sears, for being willing to come out of retirement to help out with this. We appreciate your being a part of our community, of the statewide effort, and for spending the time with us this evening to help out. We had several people that commented in the chat. One person wrote that even for people who read a lot about it, this has been very informative. So
thank you.
Appreciate that very much. So let me stop there and ask Patty or Gina if they have any. Patty. Patty's muted.
You're muted.
Sorry. I work in healthcare, and I really appreciate hearing your insight, your point of view, and how you clarified this is scientific data, this is my point of view. I really appreciate that a lot. Thank you, Jay, for hosting. I think this was very informative and really nice to see some people join in and participate in the conversation via the chat. Just as a reminder, this will be posted, I believe Anthony can clarify, out on the YouTube channel for us to be able to look at, and it's been recorded for Facebook. So it'll be available to add comments to and get more information you can always reach out to Anthony Wilson at the town office for any additional questions as well, and your local doctor.
And we will post this at townofbelgrade.com, which is a wealth of information available there.
Well, thank you all.
Well,
Have a
thank
good
you.
evening. Be safe and
Thank
very
you.
much. Take care. Good night.
See you.
Good night.